Good afternoon. Welcome to the Mary H. Weiser Center monthly webinar. As always, we continue to focus on the social and emotional aspects of living with food allergy. I'm Kim Menzel, and I'm the clinic's food allergy counselor here at the Michigan Medicine Allergy Clinic. We're one of the very few clinics across the nation to have a full-time counselor on our team, and we do take a holistic approach to food allergy management. In addition to our allergists, the team includes nurse educators, dietitians, research coordinator, and myself. My position continues to be funded by a generous donation and the support of the Mary H. Weiser Center's work. The center was recently named a Discovery Center of Distinction by FAIR in recognition of their advances in biomedical research into the origin and treatment of food allergy. You can visit uofmfoodallergy.org to learn more about their many research initiatives and their pursuit of a cure for food allergy. Today, I'm so pleased to be joined by Dr. Charles Schuler IV, Assistant Professor in the Division of Allergy and Clinical Immunology, a member of our Michigan Medicine Mary H. Weiser Food Allergy Center, and a full-time allergist at our clinic, seeing our food allergy patients of all ages. As an allergist immunologist, Dr. Schuler cares for patients with a wide range of conditions, including food and drug allergies, asthma, allergic rhinitis, aspirin-exacerbated respiratory disease, and venom allergy. He was one of 3 recipients of the Michigan Food Allergy Research Accelerator Program pilot research grant in 2019 for his research project investigating the biomarkers and mechanisms of food anaphylaxis. Dr. Schuler's research focuses on food allergies, where he hopes to better understand how and why they occur and to find better ways to test for them. We'll be talking about this today. With more than 50 million Americans reporting that they experience some type of allergy every year, he is ardent in discovering better ways to diagnose, treat, and manage allergies and other immunological disorders, always with the goal of improving quality of life for our patients. Today, we're going to bring our focus on returning to school with food allergies, back to daycare, back to school, and we're hearing from all of our parents around their questions, concerns around that transition. We'll begin our conversation with the video that was recently created by the Weiser Center, and we'll dive into our discussion. Dr. Schuler is also going to share the goals of his current research, analyzing samples taken from patients during oral food challenges to look for the biomarkers of food allergy, with the goal of improving the way that we can diagnose. We need you to contribute. Please join our conversation by sending a message using the Q&A function. We'll take your questions throughout the hour, and it will help us speak to things that are really on your mind today. Now, let's watch the back to school video that was recently produced and released through the Weiser Center.
I'm Dr. Jim Baker. I'm the director of the Mary H. Weiser Food Allergy Center. We felt that this year back to school would be particularly difficult for our food allergy families, given the disruption from the COVID pandemic. So we decided to create a video that would help you with back to school and help your schools prepare for this. We have created this video for you to get a quick but comprehensive evidence-based introduction to the various aspects of food allergy and return to school. This video is not a replacement for medical advice, and for any specific questions related to your child's allergy, please contact your doctor.
Now more than ever, families with food allergies need support and a well-formed plan before going back to school. You can watch this video all the way through for a more comprehensive review, or skip to a specific section for a quick refresher.
Recognizing signs of food allergy is an important part of management. Resources such as the Food Allergy Action Plan, which your physician can provide, can help you recognize a food allergy reaction and guide you on what to do. Review this resource with family, teachers, babysitters, friends, and your child so that everyone is familiar with how to recognize a food allergy reaction. Signs of food allergy are divided into mild symptoms such as itchy mouth or a few hives, and severe symptoms such as repeated vomiting, shortness of breath, wheezing, or throat closing. Most symptoms occur within an hour of eating a food allergen, and many times symptoms can occur immediately. When a food allergy reaction happens, do not panic. For one mild symptom, such as hives around the mouth, give an antihistamine like cetirizine, which is also known as Zyrtec, or diphenhydramine, also known as Benadryl. Do this as soon as possible and watch closely. For mild symptoms or 2 or more body symptoms, such as nausea and itchy throat, or for any severe symptoms like wheezing or throat closing, this may be anaphylaxis. Give epinephrine immediately. If a mild symptom worsens even after taking an antihistamine, give epinephrine immediately. If you are ever unsure about whether or not to use epinephrine, use epinephrine. The longer you wait, the harder it may be to stop a reaction. Do not rely on antihistamines or inhalers to treat anaphylaxis. In addition, make sure epinephrine autoinjectors are not expired and stored at room temperature to maintain their maximum effectiveness. Avoid exposing them to extreme temperatures and do not leave them in the car or put them in the refrigerator. Always have 2 epinephrine autoinjectors available with you. Some reactions may need more than 1 dose of epinephrine to treat. Next, we will show you how to use some of the most common models of epinephrine autoinjectors: EpiPen, AuviQ, and Adrenaclick. Please be aware that our video does not cover all of the available models of epinephrine. Hold the EpiPen like a microphone. Do not place your thumb over either end of the EpiPen. Keep the blue safety cap side away from the body. Remember, blue to the sky, orange to the thigh. Remove the blue safety cap. Press hard to inject the EpiPen into the muscle of the outer thigh and hold for 3 seconds. It will make a very loud click. Remove the EpiPen and discard safely. It cannot be used anymore. Rub the injection site and lay down to help the medicine spread throughout the body. You should expect to feel your heart race and for symptoms to improve within a few seconds. Call 911. If symptoms return or do not improve within 5 minutes, inject your second EpiPen immediately. Remove the AuviQ from the outer case. The audio instructions will start. Remove the red safety cap. Press hard to inject the AuviQ into the muscle of the outer thigh and hold for 3 seconds. It will make a very loud click. Remove the AuviQ and discard safely. It cannot be used anymore. Rub the injection site and lay down to help the medicine spread throughout the body. You should expect to feel your heart race and for symptoms to improve within a few seconds. Call 911. If symptoms return or do not improve within 5 minutes, inject your second AuviQ immediately. Hold the Adrenaclick like a microphone. Avoid putting your thumb over either end. Remove the safety caps from both ends. Place the red end of the Adrenaclick at a 90-degree angle perpendicular to the outer thigh muscle. Press hard to inject the Adrenaclick into the muscle of the outer thigh and hold for 10 seconds. It will make a loud click. Remove the Adrenaclick and discard safely. It cannot be used anymore. Rub the injection site and lay down to help the medicine spread throughout the body. You should expect to feel your heart race and for symptoms to improve within a few seconds. Call 911. If symptoms return or do not improve within 5 minutes, inject your second Adrenaclick immediately.
Avoiding foods that may cause a reaction is very important in preventing food allergy reactions. Understanding how to read food labels is key to avoiding problem foods. Read every food label every time to decide whether a food is safe. All pre-packed foods in the United States are required to list if they contain one of the major food allergens: milk, egg, wheat, fish, peanut, tree nuts, soy, and crustacean shellfish, such as shrimp, lobster, or crab. Sesame will soon be added to this list. Other foods may not be listed in the same way that the top 8 allergens are. Look for these foods in the ingredients section. There is another section of food labeling called the precautionary allergen label section. This includes phrases such as may contain or processed in the same facility with, etc. This indicates that the food may have come into contact with an allergy food even though the allergen is not an intended ingredient in that food. These labels are placed on foods at the discretion of the manufacturer and are not mandated by the FDA. Simply stated, it is not required that food companies use such labels. When in doubt, do not eat the food. Working with a nutritionist can be helpful in better understanding food labels, knowing what are good substitutes to the foods that can't be eaten, and creating safe meal plans. Companies can change labels, so it is important to read the label every time you buy it.
Safely living with food allergies is a team effort. It is important to communicate with schools to keep a positive and safe environment for your child. Communication equals education. Before going back to school, please review these essential steps. Speak with your child's allergist and healthcare team to discuss a plan for going back to school that is appropriate for your child's age. Get an updated copy of the Food Allergy Action Plan for both your home and school. Also, update your epinephrine and histamine supply. The Food Allergy Action Plan and medications will need to be turned into the school at the start of the school year. Speak with school nurses, school representatives to come up with a plan in case an adverse food reaction happens at school. Contact your school food director to discuss dining accommodation options for your child. Reach out to your child's teacher to talk about how to accommodate your child's food allergies in the classroom. It may be helpful to prepare a special snack box for your child to take to school. For college students, reaching out to dining services, housing services, and create an emergency response plan for your dorm room, dining hall, as well as other areas of campus. Last but not least, make it a habit for your child to communicate about their food allergies on their own behalf and develop age-appropriate food allergy management skills. For older children, place food allergies into the medical ID section of cell phones, so in the case of an emergency, a first responder can get the information from the phone. It is also a good idea to wear medical alert jewelry such as a necklace or bracelet. Due to COVID, hand sanitizer use has become very popular, but hand sanitizer does not effectively remove allergens from surfaces. Make sure your child has access to wipes or a place for hand washing with soap and water in case they come into contact with food allergens during the school day. If your school requires students to wear masks, create a plan with your child's teacher about how to recognize quickly signs of a food allergy. This may require your child to remove their mask to look for signs such as lip swelling or hives around the mouth.
A food allergy can bring many changes to a family's everyday life. It's normal to be overwhelmed or anxious. If you're not sure where to start, many allergy clinics offer or can refer you to counseling. Food allergy counseling can guide patients through food allergy appointments, testing, and treatments. We can address fears that are a barrier to skin prick tests, blood draws, oral food challenges, and oral immunotherapy. We can help families develop coping strategies and tools to navigate food allergy management. Cognitive behavioral therapy helps identify and reframe negative and inaccurate thoughts to reframe them to positive, accurate thoughts. We can create a game plan for patients and their families throughout different stages of life to move from infancy to college and beyond.
There are new treatments for food allergy that are currently being explored. One such approach is oral immunotherapy, or OIT for short. This process involves building the body's tolerance to a food a person is allergic to. The goal of this treatment is to prevent a life-threatening allergic reaction in case the food was accidentally eaten. OIT must only be done under the supervision of an allergist. There are other approaches that are currently under research. These include immunotherapy in other forms, such as patches on the skin or tablets under the tongue. There are also vaccines being developed for food allergy treatment. If you are interested in exploring new treatment options, please talk to your allergist.
In this video, we went over the signs and symptoms of food allergy and anaphylaxis, what to do during a reaction, as well as different aspects of living with food allergies. We hope you found this video helpful. This video is not medical advice. For any specific questions regarding your allergies or your child's allergies, please contact your allergist. More food allergy education resources are listed below. Thank you.
So, Dr. Schuler, thanks so much for joining me today. Can we begin with your thoughts on what we just heard in the video?
Well, good afternoon, Kim. It's a pleasure to be here today, and I want to say thanks for having me. The video gives an excellent summary of key points around managing food allergies. But when you watch the video all at once, it can feel overwhelming to think about the reality of managing your own or your child's food allergy. Particularly for anyone with a recent food allergy diagnosis, I really recommend focusing on one area of food allergy management at a time. And this can help reduce feeling overwhelmed and allow you to gain competence in specific areas, one at a time. For example, focusing on learning the signs of an allergic reaction may be a good place to start. Another one is to practice using your epinephrine autoinjector using the trainers that come with each device. As you gain knowledge and skills this way, that feeling of being overwhelmed starts to be replaced with a feeling of more calm competence, which is really important. And so the video can then be used as kind of a reference tool where you can go back to this or another resource later on, which can help reinforce some of these key skills as you learn them over time.
We just received a question, so we're talking about recognizing symptoms and treating. So a listener who's watching us live, she said, would you consider adding sense of dread and in quotes, like, I'm going to die. So if a child says this as a sign, that should that demand immediate use of epinephrine and a call to 911. So what do we do? Because we know kids can sometimes say things that parents aren't sure how seriously to take that or how to respond.
I think it's a fantastic question, and whoever put that in, I want to say thank you to that person. That sense of dread or impending doom is the way it's often put in the medical literature, is a pretty well described symptom of anaphylaxis reactions. It's not understood precisely where that comes from, whether that's because you're feeling something in your blood pressure or your lungs or something else, or if it's a natural, profound anxiety response to a reaction. And as a parent, we'll talk about this in the upcoming sections, but it's really tough sometimes to know what your kids are trying to say. And I have an almost 3-year-old, so I'm particularly aware personally of that issue. I think particularly when the sense of dread or a statement of I'm going to die is paired with an obvious objective symptom and a known ingestion, I think that is a pretty reasonable thing to include. And according to our plans, if you hit 2 symptoms together, particularly after an ingestion, it's time to use that epinephrine and go to the emergency room. And so I would not ignore that statement. On the other hand, if it's a much less clear exposure and it's the only thing that you're hearing or seeing, I could understand how a parent who knows their child very well might want to just wait a minute and see what's happening and see if this is an anxiety response that will pass on its own or an evolving food reaction. But the bottom line I will say is you're never wrong to use epinephrine. And if you're not sure, the answer is yes. The risk to your child or to you is extremely small from using epinephrine. And really the only reason we tell people to go to the emergency room is not because epinephrine is dangerous but because we want to make sure people are monitored and safe, because epinephrine is short-lived. So this is one of those situations where I think you should give the symptom credence. I think you should believe it. And if you're not sure what to do, then give epinephrine.
So could they follow up with, so if it's a child that, is verbal, if they're able to share that, are you feeling anything else in your body?
I think that'd be very smart.
And so I also hear parents sometimes, so a child will say, on the way out the door to school or daycare, preschool, my throat is itchy or my tummy hurts, and they did just eat breakfast. So I think it can be hard to know how to respond to the comments that a child might make. Does it mean they're anxious about going to school? Does it mean they're anxious because they just ate? Or does it mean they're in danger?
I think that hits exactly on this issue of constant vigilance that so many people who live with food allergies in themselves or in their family have to handle. And children are wonderful at pushing our buttons, at getting parents to do what they want. And so I think you have to look at something like that in context. So is this a pattern? Is this a daily experience, a daily statement? Is this a child who otherwise does not want to go to school anyway, and this is a new tactic? Or is this unusual? Is this new? Was there something new about breakfast? And so I think that has to be very situationally assessed, and it's hard to give a general prescription for that one. It's a tough one. And again, I think the theme of this hour is going to be trust yourself and trust your kids. And obviously, if that's the first time that happens, I think give it some credence, believe it. If it's the 10th time it's happened and there's not been a reaction before, then maybe you're looking at a behavior more than a reaction.
I think that is an excellent way to think about it, is put it into context. So there are, of course, different issues depending on the age of the child. What are concerns commonly expressed by parents of younger children, those preschool, elementary age children? What are you hearing from parents these days?
Well, having young children is an experience like no other, especially in the last few years since the pandemic has happened the last year and a half. So much is new, so much is exciting, but having a young child with a food allergy can be quite daunting. The first time in daycare, maybe with a new caregiver, or going to school for the first time can be particularly anxiety-inducing. The loss of control, separation, these can make this particularly difficult. So some of the common concerns that I hear include things like, what if my child can't express themselves? What if my child's symptoms of a reaction are missed? What if my child receives a food allergen by mistake? What if my child's bullied? Questions about eating in lunchrooms versus eating in classrooms, questions about allergen-free rooms or allergen-free schools, those come up quite a bit too. In this age category, as the allergist, I really try to focus on helping the child in an age-appropriate manner know what their food allergies are, if possible. And I start to ask the child what they would do if someone offers them any food. I don't always have the chance to link it back to the allergy directly, but maybe it's just what's in this food is the only thing we want to train, particularly in someone who's 3. Medical alert wearables like bracelets or jewelry can be useful in this age group as well. And lastly, I always really make sure I provide the best documentation I can. That includes a food allergy action plan that everybody gets. I also will write letters if I need to try to explain things, and just making sure that families in general have what they need in this phase of life.
So you and I were talking before the webinar today. We're getting some excellent questions about, the return to daycare, for example, with younger children that were just recently diagnosed, during the pandemic, and concerns for how, when children are eating together, they're younger, and how do we help daycare providers understand what are the steps? So what can parents say to daycare providers in those young settings that will really help them understand how to appropriately take precautions and respond? I'll just throw that out. Is there anything you would say, these are important things to add in that conversation for parents?
I think this is a critical issue because how you learn to communicate with people outside of your home early on when your child is young or your children are young is going to set a pattern for how you communicate with people for a long time. So what I really recommend is coming in with very open hands, kind of interpersonally, and say, ask questions first. So what are the eating arrangements going to be for my child and for the classroom? What do you know as a daycare provider about food allergies? Have you handled food allergies before? How did that go? I would really recommend for parents that you should really try to build a picture of what's inside the daycare provider's minds about what food allergies are and how they're best managed. And it's only once you really understand that position and understand their experience that I think as a parent you can begin to set expectations for your own child. And so by layering on what you need and what your child needs, specifically onto what's already been established in the daycare, I think allows you to have a particularly potent conversation that will lead to actual change and not something that's more superficial. So that's how I would start that conversation. As far as safety for young kids in daycare, the big issue with little kids is they love to share. We all know this. And so the eating situation can be important. Particularly in very little kids, it's important to have them in, potentially in high chairs or in a seating arrangement that gives everybody a little bit of space, that's washable, that is pre-washed, soap and water. Recognizing that food allergens can stick around on hands and in mouths after eating. So not a bad idea to wash hands, not a bad idea to wipe off faces, not a bad idea to give everybody a sip of water when they're done. And honestly, that's true for all kids, always, without food allergies. But just making sure those are formal steps can be a nice way to make sure any allergens that are consumed in a classroom to which the child's sensitive, that those aren't carried then onto the blocks or the balls or the toys or whatever else.
So as we continue to look at sort of these stages, and so what are the issues for middle school age kids? If we think about as kids get a little older and they're moving between classrooms, more independence, what might parents want to think about, or what might they want to include in their conversations with teachers and school staff?
So middle school is a time of profound change, as we all know. And it's the age where children really begin developing their independence in a strong way. And this is the age where there might be more meals away from family. For example, middle school children might eat out a little more. They might eat with their friends at their friends' houses a little more. They might actually have some money to buy their own food, and so that can be a bit of randomness in the situation as well. And this means that middle school age children really need to start having their epinephrine with them, potentially, if these behaviors are becoming prominent, rather than at home in a bag with their parents. This tends to bring up questions from parents about, will my child know when an allergy is happening? Who carries the epinephrine? Is it the parents or the child, or both? Do we need more epinephrine so that more people can carry it? Should we split up the twin packs? The answer to that is always no. When and how can the child eat out or eat at a friend's house? In addition, social pressures become a bigger deal yet in middle school. So people may ask, what should I do if my child is bullied or pressured to eat a food allergen. This is also the age where the physician-patient relationship starts to change a little bit, and it goes in lots of directions. Sometimes the child will trust me as their allergist more than they did before, and they'll ask me their own questions. And we'll start to have spontaneous conversations in the visit, which can be really productive. Sometimes the child trusts me less, and I can't get a word out of them at all, and that's normal too. Either way, this is in this age category in these visits, I really start to focus on teaching the child not just what their allergies are or how to ask about what's in food, but we really start focusing on how to handle food allergy themselves. I don't expect middle school aged brains to remember all of the conversations we have, but I do expect them to start understanding how to use the epinephrine, how to begin to advocate for themselves, and at least how to look at a food label and say, this is what might be in this food. And so practicing some of those things becomes a key part of these visits for me.
So we did get a good question from an audience member. Did you see? So did
I might have missed it.
we?
You'll have to
No,
repeat,
I'm
please.
sorry. I was reading. So how do we deal with teenagers? We haven't gotten to teenagers yet, but we'll get back to that one. How about when kids are wearing masks at school, and how can teachers look for hives and allergic reactions after lunchtime when we have partial face covering? How are we telling parents to think about that, or what would be advice for school personnel?
I think there's a few key points to recognize in that situation. One is that masks are a mitigation measure. They're not a force field like in a science fiction movie. So they reduce the rate of COVID transmission. They do give some protection, but they're not 100%. And so a quick check to look at a kid's face is probably not the end of the world. It's probably not taking the rate of COVID from 0% to 100%. So I don't think we should view the mask as something that's permanently closed. It's okay to do a quick check. I do that all the time in clinic visits, and I think that balancing practicality with protection is appropriate. Number two, most reactions in children, while a lot of the reaction can be on the face, there's usually skin-based manifestations in other places as well. And so it's also okay to take a look at the neck, to take a look at the upper back or the arms, maybe to look at the belly, if there's comfort and that's been established kind of interpersonally by the parents already. So those are other places to look as well. It's also appropriate to watch kids' behavior. You know, children who are younger in particular don't express themselves necessarily the way adults or older kids do. And so looking at behaviors anyway is a smart thing. So if a kid is really quiet and withdrawn after lunchtime, if they're scratching, if they're hyperactive and it's not clear why, if they seem to be breathing oddly, those are all reasons to do a quick check. Part of it too is I don't think we have to expect a food reaction after every meal. And so I don't know that we need to recommend every kid with a food allergy is always checked at a certain time after every single meal, particularly if they've done well and the daycare has not experienced a lot of reactions. Obviously, that's individual specific, and I think parents are within their rights to ask for a specified check, and I'm not precluding that option. But I just want to make a point that playing into the constant vigilance in that way doesn't have to happen for every child.
So it occurs to me, so middle school can be a time that kids might start carrying their own epinephrine, the auto injector. I know we talk in clinic sometimes about what are the different methods to do that. Some of our allergists recommend like a flip belt, that is, it can be worn under the clothing, under the shirt, it's close to your skin, so it's not a fanny pack, it's not on the outside. Perhaps it's more, kids maybe feel more comfortable, or it's going to draw less attention. What are some ways that kids can carry safely when it's time for them to start to assume that responsibility?
So this is something we do in the clinic regularly, and there's no one perfect answer, as you pointed out. So again, I always start with asking questions and trying to understand what's already happening, because the best way to have success in a health behavior is to make it compatible with existing behaviors. So if you know that your middle schooler already carries a backpack to every classroom and to gym class and to music class and to art class, or whatever the extracurriculars are, or whatever the extra classes are, then the backpack is a natural place for the epinephrine to reside. Some kids' clothing has pockets, and some kids don't mind putting it in a pocket, especially if it's shaped like a cell phone. Maybe they're kind of cool, I don't know. I've had that statement once or twice. If they have an epinephrine auto-injector that's not pocket compatible, it's not shaped right, or something like that, then yes, those kind of travel belts can be very appropriate. If the clothing's not compatible with that and they don't carry a backpack, then a small kind of style backpack or a small like style bag can be a choice for some children. It can be a place to put other things that they want to bring with them, or that you think they need anyway, whether it's a little notebook, or if they have dare I say it, a flip phone or a smartphone. There are other ways to meld the injector into their existing habits.
What kinds of things do they have to consider in terms of temperature? So is it safe for them to carry it on their person if they're out at baseball practice or at track practice, instead of having their coach take care of the auto injector? Can a child have it on their person? Is that okay? What are the temperature considerations?
So the temperature considerations are relatively broad. You don't want it to freeze. Obviously, that's not the best. And you don't want it to get up to too high of a temperature. So I always say that in general, a rule of thumb is that the epinephrine is comfortable where you're comfortable in a t-shirt or short sleeves. So room temperature is best. If it's a bit warm and you're talking into the 80s Fahrenheit, it's probably fine, particularly for a short period of time. If you're getting up over 90 or 100, you should really think about some sort of refrigeration or cooling technique. Same as you head down in temperature, lower and lower is not as good. So if you're comfortable, it's comfortable. It's a biological compound that's designed to be active because it's a naturally occurring chemical in our bodies. It's designed to be active at our body's temperatures and where we're comfortable. So that's kind of how I look at it. I try not to give a precise cutoff, but rather a general something you have access to at all times, which is would I be comfortable in a t-shirt right now?
I think that's excellent a way to frame it, especially in those conversations parents are having with the kids. That gives them a point of reference that can make it more concrete. So now
Right.
Let's jump into what are our relevant issues for our high school and college age students?
It's a key next step. So we talked a little bit about independence. Well, let's talk more about independence, because that's the name of the game in college and high school and college. High school and college ages are really the start of adulthood, right? And so in this age category, there's much more independence. Many children and young adults start driving in this age category. They might move out of the house, get a job, go to school. And what really becomes obvious is that parents' lack of control is absolutely front and center. So that little 5 and 10-year-old you could really keep track of, that sense of control is long gone now. And this age tends to come with some more risk-taking behavior too. And so parents are often much more worried about their young adult children than the patients themselves are. And that's very challenging psychologically for parents and for kids, because expectations are no longer aligned at all. So I get a lot of questions around again, recognizing allergy reactions, how to do that properly, how to avoid food allergens. We have to go through that all again as children become adults because now they become responsible. How to consistently carry epinephrine. I can tell you that the teenage and young adult brain has a hard time remembering how to do things consistently, habitually. That's much more difficult, and that remains the case into the 20s. Proper epinephrine use, how to remember how to use epinephrine. Again, we're reteaching that in this age category as well. And this is also an age where young adults learn to cook, or they learn to eat out. They learn to manage their own diet. And so how do we maintain a balanced diet? How do we try new foods? How do we eat out safely? Those are all key features as well. So in this age group, I really work on educating the patients themselves. I really try to give the patients reasons to focus on managing their own food allergies, whether that's remembering a difficult experience they've had, whether it's thinking about how their parents would react to bad reactions. I try to find something that's motivating to my patient so that then we can start doing things like reteaching epinephrine use, reteaching label reading, restaurant interactions, and other skills of that nature. I also, again, really educate on the risks of food allergy and focus on the risk of delayed epinephrine use. A delay in epinephrine use is the #1 reason why food allergy reactions don't go well. And so I want to make sure that's understood in this age category. And it's something I reiterate. I get to be a bit of a broken record in these visits, which is actually a good thing. And this is all because I really want these patients to successfully make the leap to independence during this phase of life. And it's a time when we can have a really outsized impact on everybody's lives.
Absolutely, so true. It reinforcing the message in different ways and to really address those new developmental challenges. And we have a great comment. Somebody wrote in, be sure to include the student in the conversation. If they're part of the plan, they're much more likely to be compliant.
Very true.
Seeing, where we can get buy-in. What are their ideas about how to carry their epinephrine auto-injector? What are their ways of communicating with other people about having an allergy and what that means?
I think that reiterates the importance of open-handedness. So coming into a conversation with open hands, not a closed fist, psychologically is really powerful in interacting with somebody who may not agree or may not see things exactly the way you do when you start a conversation like that. And I think that comment is just A+. So thank you to whoever said that.
We have another question. Can you carry one Auto-Q or epinephrine auto-injector, whatever brand you're carrying, and have your teenager carry another? They're mostly with parents or at school where the nurse has another set. So how to handle that?
That brings up two issues. One is, should you split epinephrine two-dose packs? I recommend not doing that if at all possible, because you really want to have that second dose on hand and available within 5 minutes. And while school nurses do a heroic job keeping our kids safe and healthy, sometimes the nurse is 10 minutes away instead of 5. Now, I acknowledge that cost can be an issue in these situations, and the cost of epinephrine auto-injectors is enormous. So if that's what you absolutely have to do, then I acknowledge sometimes people feel trapped. But rather than just feel trapped, ask me for help. Ask your allergist for help. Oftentimes, we can plug you into a low-cost program. We could just write another prescription. I can write a letter to insurance explaining why something is necessary. I will go to bat for you. I am not afraid of the insurance companies, and I'm not afraid of anything like that, and we will get it done. Whatever our patients need, we're there to do it. So engage your allergist and say, hey, we're running into this problem, can you help? The other issue I just want to mention that this brings up is that there are different laws in different states about unlabeled or unprespecified epinephrine in schools and other locations. Schools in Michigan, at least last I checked, are not mandated to have non-specific epinephrine that's not earmarked for any one person. They are allowed to, but they're not required to. And so certainly you can clarify that a school nurse may be armed with an unspecified autoepinephrine injector, but I can't guarantee that that's the case in every school. And I think that's one of the reasons why I still recommend taking control of that aspect of care where you can, and just getting a second or a third or a fourth set from me, from the pharmacy that I can help you with.
Absolutely. And then we also think about the college age students eating in the dining halls. And we know at the University of Michigan, the Weiser Center and our clinic were actively involved with getting the dining centers equipped with having epinephrine there on site. And so that may be the case at some of the universities, but as you said, we can't count on that unless we check that out. So when our college age students are going back this fall, ask those questions, meet with somebody from dining hall and ask specifically, do you have epinephrine auto injectors on site? And when your child hears, no, they don't, okay, remember, you have to have that with you all the time. No one, there's no one else who has that available to you. You need to carry it. But it's also good for them to realize that in some of these settings, people will have had a lot of training and they're equipped to help and they have the epinephrine on site. But it's good to know the setting, know the environment, so I can respond accordingly.
And I think as a parent on the tour or when you're doing orientation, saying, oh, you do have injectors stocked. Where are they? Can you please show them to me? And that, I think, too, gives a sense of clarity about where they actually are. If they're way down the hall and the dining room is somewhere else, or there's a special dining room or whatever, there's a lot of different considerations, and actually seeing a physical space can be really valuable. And then, going to the resident advisor or going to the security person or someone who's sitting at a desk and say, do you know how to use this? And just handing them your auto injector demo will actually tell you a lot about the environment as well. So I think doing some of those practical tests, that can also add to that sense of security or give you some motivation as well.
I think that makes so much sense, because it doesn't really help if there's one person on the entire team who's trained. They may not be there. And so
Exactly.
How universal is their training? And that's a way to find that out. And then it's an opportunity. Are they open to receiving some training, some information? And our clinic can help get you the information. You can use this excellent video to help with your education of people that you're coming into contact with. So I do want to have time. I want to talk about your current research. So would you share with us what are your current research efforts related to improving our understanding of how and why food allergies occur, and the testing and to diagnose food allergy?
Definitely. Thanks for the opportunity. I'm a researcher, so I love talking about my research. My research focuses on improving food allergy diagnosis. So one of the big problems in food allergy in general is that our current testing methods, like skin and blood testing, can actually have pretty high false positive rates. And what this means is that a positive skin or blood food allergy test can be wrong. And it can be wrong up to half the time and even more sometimes. So because our testing is actually so imperfect, we end up needing to do a lot of food challenges. Now, unfortunately, food challenges expose the patient to the actual risk of the disease of food allergy, which is food anaphylaxis or food reactions. And there's a real chance of having a food reaction when you do a food challenge. It's just the nature of the exercise. So my research tries to actually leverage the fact that food challenges do cause food reactions in some people to our advantage. So we take a really comprehensive set of biological samples from people who undergo food challenges. And we include people who react and people who don't react, so we can really compare them and get a sense of key differences. And I'm particularly focused on using these samples to develop new food allergy diagnostic tools. So these include measures of food reactivity that we do outside of the body, like on blood and a test tube. We're also looking at ways to detect food anaphylaxis before or even while it happens. And this would help us better recognize symptoms and signs of food allergy reactions as they occur, and maybe even let us stop food challenges earlier and maybe have less symptoms or less severe reactions. So overall, my long-term goals are to first replace, if I can, our current food allergy testing methods with more accurate tests. And number two, make the food challenges in the future that we still have to do much safer and much more objective. And overall, what I hope to do is help reduce the need for food challenges while making actually clearer and safer diagnoses for all of our food allergy patients. And there's a lot of them. There's 30 million or more people in the U.S. diagnosed with food allergy. So this is, I think, a pretty big problem that I'm very motivated to help solve.
I'm sure that the parents that are listening are so pleased to hear, that there's constant research going on to improve testing, to improve, the way that we treat food allergies, and to continue to work toward a cure. In the video, Dr. Gupta, spoke about OIT. So we have oral immunotherapy now that we didn't used to have, and right now that's going on at our clinic for peanut. So we're advancing the treatment, but I know we want to be able to diagnose more accurately and efficiently, and we want to be able to eradicate food allergies in the future.
I think that's exactly right. And I think the Food Allergy Center's goals are really clearly laid out and stated, and the impetus of the entire center is behind those goals. And I'm very excited to be a part of that, and very grateful for the opportunities I've been given to push some of this forward.
So getting back to our back to school concerns, of course, part of parents' back to school concerns may be related to the ongoing pandemic. And we know we have some rising numbers, some variants, and parents are concerned. And you're actively engaged also in studying Michigan medicine healthcare workers to determine the longevity of antibodies against COVID-19 after the initial infection. Will you share with us, what are you learning about this?
Oh, definitely. Thanks for the opportunity. As I said, I'm really interested in making accurate diagnoses and understanding what tests mean and what they don't mean. And that applies to COVID-19 too. We've written a couple of manuscripts so far and have some ongoing work happening. Our first manuscript has been published, and in that one we evaluated the ability of COVID-19 antibody tests to tell if someone really has had COVID in the past. What we found was that the antibody tests that ultimately gained and most importantly retained FDA approvals for checking for COVID-19 antibodies had really excellent accuracy. Our second manuscript is just about to be published. It's been accepted. And what we report in that study is that after mild COVID-19 illness, patients actually produce fairly robust antibodies against COVID-19, and these antibodies are maintained for at least 6 months. And not only that, people who produce these antibodies seem to be protected from new COVID-19 illness for at least 6 months as well. So we found that fairly reassuring. One big question that then gets asked is, well, what about vaccines? Do I need to be vaccinated if I had COVID-19? So in the current phase of our project, we're actually analyzing our data to directly compare vaccination to regular infection to understand how well each protects from future infections and what the immune response looks like in both and in the combined situation. And to be clear, based on other published studies so far, I do strongly recommend people be vaccinated for COVID-19 regardless of prior infection status. So if you've had COVID, I'd go ahead and get vaccinated regardless of that history. And the reason is that the vaccines are safe and effective. There is some data suggesting that vaccination enhances existing immunity beyond where it would have been anyway. And as someone who has a son who's too young to be vaccinated, who has a sister who has special needs and is at particular risk of COVID, and as someone who treats as a doctor many immunosuppressed patients who are at profound risk of COVID-19, it's for that reason that I ask everyone be vaccinated to protect not only themselves, but actually more importantly, the vulnerable members of our community. And so I look at vaccination as a community service that you can do for others rather than as a selfish act you're doing for yourself. It's really about other people. So activate those altruistic parts of your brain, and if you're not already vaccinated, please do so. If I can, I know we don't have a ton of time, but I'd also like to say one word about our current vaccine study. Is that okay?
Yes, please.
So we in the Food Allergy Center and the Allergy Division are combined in a clinical trial that's national and funded by the NIH, where we're studying COVID-19 vaccines safety in people with severe allergies, including severe food allergies. So if anybody in the audience has yet to be vaccinated or knows someone who's in that category and would like to do so in a monitored setting with an allergist present, like me, this study would be appropriate for them. People can email vaccine, VACCINE, dash or hyphen reactions, REACTIONS, at med.umich.edu. And I think we can link to this after the webinar if they're interested in learning more about that study. So I'd encourage anybody who's interested. We're still enrolling.
Thank you for sharing that. I think it's so important for us to be able to get information out about current research that's going on so people can be involved. So in the minute we have left, I'd love to just hear your summary of recommendations for parents and caregivers with all that we've talked about preparations for return to school and daycare and beyond the bubble back out into the world.
Definitely. I got to say, for returning students and returning parents, first off, please trust yourselves. Trust your experiences. This year is definitely going to be difficult given all the changes we've had in the last 18 months, but you've done it before and you've done it successfully. The same principles hold, and I just want to say I know how resilient our food allergy families and patients are, and I know you can do it. For new students and food allergies families who've not been through school or daycare before, I just want to say take things one step and one day at a time. Pick one thing, control what you can. Recognize you can't control everything, especially when you start out. It's really tough. And remember that epinephrine is life-saving, so use it if you need it, and use it if you're not sure. Remember that we here at U of M are here to help if things are confusing or when you have a question. I love answering questions of my food allergy patients. It's a key part of what I do. Remember, too, that the Food Allergy Center and the Allergy Division are working together tirelessly to help right now in the real world and to create a future where food allergies hold far less power over all our lives. And I just want to say, I hope as the years goes by, as we have more webinars like this, as we put, hopefully, this pandemic behind us, I hope that the future, and I think that the future will hold much brighter days on the food allergy pandemic as well. And I'm just very excited to participate, hopefully, in bringing that about. So I'll just leave it at that and say thank you all for your time and attention to me.
Thank you so much. I'm so glad we ended on this. It's optimistic, isn't it? We can have an optimistic outlook. And I think with information and strategy, skill building, we can prepare ourselves for whatever challenge that we're facing in that moment. So we thank everybody for joining us today. And we're in the email that you'll get after, and you'll be able to access the resources we talked about. You'll be able to access the information on the research opportunities that Dr. Schuler talked about. And please share widely our video on back to school. That isn't just for our Michigan patients, that's for everybody. Anybody that you can share that with who could benefit. That might be the school, a daycare environment, a neighbor. They don't have to be our patients. We do this because it is our community outreach, and we want to help people feel that they have the skills they need to manage the stressors related to food allergy. As we finish up, on the behalf of the Weiser Center, I thank you for joining us, tuning in today, and those who will be watching us in the future, as our segments are all posted on our YouTube channel. Please continue to join us, subscribe, share this with others who could benefit. If you'll stay tuned, I'd love to share a mindfulness practice. So just let's take a moment and drop down into feeling ourselves just breathe in this moment, out of our thinking minds. Taking a deep breath, noticing how it feels to breathe. Letting any busyness of our thoughts, any concerns, worries, imagine letting those just come up and float away. Come back and feel yourself breathe. Bring yourself back to this moment. What's happening in your world in this moment? Noticing, we can be imagining a lot of fearful scenarios, while we can also come back and just be in the safety and security of this moment, out of the what ifs and no nos. So as we go do these hard things, as we go and face everyday stressors, remember, we can come back in any moment, find your breath, reorient yourself. Is there an actual threat? Is there a danger right now? Or is it my mind imagining the danger or threat? So come back, assess reality as it is, find your breath, take a moment, come back, and then bring yourself back to the situation at hand. And that will help you to be able to be more resilient and to manage that stress in a more responsive and less reactive or fearful way. Thank you.